Hello and welcome everyone. My name is Dr. Jayant Giri. I am the Associate Director Medical Affairs at BD for the Asia region. Thank you for joining us today for the third of our six-part webinar series highlighting updates to the 2021 Infusion Nurses Society's Infusion Therapy Standards of Practice. Trust you've enjoyed the previous two webinars and are looking forward to the next ones. Today's webinar is titled Vascular Access Device Planning. This webinar will help us expand our knowledge on the factors to consider when we choose the appropriate device for our patients. The objectives for today's webinar are to discuss key peripheral intravenous catheter definitions and the INSS categorization of three types of peripheral IV catheters. We'll also review the practice recommendations and evidence for short peripheral IV catheters, long peripheral IV catheters, and midline catheters. We will discuss the necessity to consider nature of therapy and the selection of peripherally inserted central catheters versus other central vascular access devices. As well as we'll talk about various device selection tools or algorithms and difficult IV access assessment and escalation tools. Before I introduce our speaker for today, there are a few announcements. Firstly, for optimum viewing experience, we would recommend that you're not connected to a VPN. Second, there will be several poll questions throughout the presentation, and you would see the first question on your screen now, which reads, what type of role would you best identify with? Please click on the most applicable response and submit. To receive a certificate for today's webinar, at the end of the webinar, you'll be requested to respond to a 3-question survey that will automatically appear on your screen. Please do not close your browser. Once the survey is completed and submitted, your certificate of completion will be emailed to you within a few hours after the conclusion of the webinar. I would now introduce our speaker for today, Trisha Clyden. Please join me in welcoming Trisha. Trisha has 25 years of experience as a nurse practitioner in pediatric vascular assessment and management at Queensland Children's Hospital, Australia. She is associated as a research fellow with the Avatar Group at Griffith University, Brisbane, and in Australia. Trisha's dual role between clinical and research activities provides a unique opportunity to improve vascular access outcomes for pediatric patients. She has published over 40 papers in peer-reviewed journals. Trisha is a key opinion leader, national and an international speaker, an educator for peripheral and central venous access device assessment, insertion, maintenance, and management of complications. Trisha was recently awarded Researcher of the Year in 2017 and at Australian Vascular Access Society's Janet Petit Scholar 2019. Let's tap into Trisha's unique expertise of INS standards, as well as a researcher and clinician. Trisha, it's a real pleasure to have you join us today. I will now turn the presentation over to you. I think Trisha is on mute.
Sorry, there's always a few technical hiccups, isn't there? I'd just like to thank BD for inviting me to share some of the experiences that I learnt whilst being an author on the INS standards, and I hope that you all get a lot out of the presentation today. I won't go over the objectives again. I think Jayant has covered them quite nicely. In addition to the disclosures that this presentation is sponsored by BD, I do have to disclose that I am part of the Avatar Group, as Jayant mentioned. So as a member of that group, we have been very fortunate to receive various government, hospital and industry-sponsored grants to undertake a lot of our research. Anything that I discuss in these presentations that are related to any of those grants, I'll highlight, and I won't discuss any products that are off-label during the presentation. So thank you for the introduction, Jayant. And I'll just move on to why vascular access and choosing the right device at the right time is so extremely important for all of our patients, from neonates to adults. So when children and adults become unwell and need hospital admission, it is often necessary to access their vasculature to undertake diagnostic tests to infuse the different medications that might be necessary for treatment. And generally, a peripheral intravenous catheter is considered the fastest and simplest way to access a patient's vasculature, whether they be a neonate, a paediatric, or an adult. But is this always the best option? And whilst it might be the easiest option and the most accessible option, it might not be the option that is most appropriate for the duration of the patient's treatment. So we need to think, has due thought and consideration gone into what type of intravenous therapy is needed and how long is the intravenous therapy likely to be required? And today, with so many choices and so much evidence to inform these choices, it is no longer acceptable to just simply insert a vascular access device without considering whether it is actually the right catheter for this patient at this time, and without considering whether this patient and the catheter that you're inserting into this patient at this particular time is going to suit their particular treatment plan. So vascular access insertion is not without risk or emotional stress. So if we're going to undertake a procedure that is likely to have such a profound effect, we should really make sure we put some thought into our plan. Because without planning, we're really just flying by the seat of our pants, hoping we're doing the right thing for our patient, and our patients really do deserve better than this. So planning ultimately should be the first step in any vascular access device selection and insertion. So what are the therapy needs? How healthy is my patient's vasculature? What are the device selection options? And what are the site options? And remember, this plan must be dynamic and flexible. It shouldn't be set in stone. There needs to be capacity for it to change as a patient's vascular access needs or treatment changes. So ultimately, when we're planning our vascular access approach, we need to ensure the longevity of a patient's vasculature through vessel health and preservation. This needs to be the key to any collaborative decision, and particularly in my field of work where I'm most often looking after neonates and paediatric patients, I'm particularly interested in how, or concerned about how I'm going to make sure that my patient's vasculature is preserved all the way through to their adult lifetime, because children do become adults and we need to make sure their vasculature is not compromised once they reach the adult organisation. And so really there's no better way to preserve a patient's vasculature than to not insert a vascular access device. So this should be the first question: is vascular access necessary? Is there an alternative therapy? And this should occur where possible and appropriate in conversation with the patient. This should form part of the informed consent, which is important even for devices as pervasive and presumably as easy to insert or innocuous as peripheral intravenous access devices. So the next step is, if intravenous therapy is considered the best course of action, the next logical question is the intended infusion peripherally compatible, or is a central venous access device required? So what will be the treatment regime? How many concomitant therapies will be prescribed? What is the intended duration of therapy? And to fully appreciate this must be a collaborative decision between the entire healthcare team, and this includes the patient and their caregivers. And finally, when we consider the various vascular access device options, consider patient factors including previous infusion therapy, their history, and ensure that the least invasive device with the fewest lumens that will meet the patient's lifestyle needs and promote vessel health and preservation is inserted. So depending on the complexity or acuity of the patient, the most appropriate vascular access device might not be one, but actually two. So this might reduce the need for large multi-lumen devices, and this should be considered in the context of the patient's vasculature. So what's right for one patient won't necessarily be right for all of your patients. It really is an individualised and constant decision-making process. So once the decision to insert a vascular access device has occurred and inserted, vascular access device planning really doesn't stop there. That's not the job done, because that is really just a point in time and probably the shortest part of the vascular access journey. So at every daily huddle, a conversation should occur to determine, does the vascular access device currently in situ meet the patient's infusion therapy needs? Has their treatment escalated? Has their treatment de-escalated? Is the vascular access device still necessary, and can it be removed? And this decision to remove a vascular access device should be centred around the context of, is it necessary, not whether or not a CVC can be removed and replaced with a PIVC. And so then if we look at this more detailed examination of the patient, treatment and device factors to consider what is the most appropriate vascular access device for each individualised episode of care, we need to really consider these factors together as a unit and how they interact with each other. So a recent systematic review by Heng, published about 18 months ago in the American Journal of Medicine, aimed to determine the predisposing patient, catheter and healthcare-related factors that contribute to peripheral vein thrombophlebitis in the upper extremity, and this was in adult patients. So the authors examined 25 full-text articles that they ultimately included in their final analysis. And what they found were that patient-related risk factors included female gender, immunocompromised patients, when there's a intercurrent illness, any comorbidities such as diabetes mellitus, malignancy, previous thrombophlebitis, burns, and a higher hemoglobin. And a lot of these patient-related factors we're hearing time and time again in various presentations that we're seeing when we attend the AVA or INS conferences. So it's good to see that similar themes are occurring in the published literature as well. And then if we look at the catheter-related factors, they identified the catheter size, the duration of the catheter dwell, the site of insertion, so the antecubital fossa and the wrist were identified as having greater risk in comparison to the forearm. Again, this is very similar and coming through in lots of presentations. The location of insertion, or more specifically the actual department of insertion. So a emergency department was associated with higher risk compared to general clinical areas. And other catheter-related factors included number of catheters. So the greater number of catheters that were inserted, the greater the risk. And finally, catheter material was always also highlighted as increasing risk. So then looking at the treatment-related factors, these often complement the device factors. So again, longer duration, multiple or frequency use, and the drug characteristics, for example, the type of infusate, and often the type of infusate that is being reported in the literature now are really some very common antibiotics that are frequently administered in our daily practice. So the aminoglycosides, dicloxacillin and cloxacillin. And a theory that is being postulated is that the increased risk of some of these drugs in relation to thrombophlebitis might be related to the microparticles in the infusate. So a drug that we commonly administer in Australia is flucloxacillin, and this is usually empirical treatment for any non-MRSA Staphylococcus aureus infection. And if you talk to a pharmacist, they say under a microscope, it looks like fine shards of glass. So we need to consider how that's going to be infused into our peripheral veins as well. And then the administration of corticosteroids actually had or was found to have a protective effect. So now that we've looked at the risk factors for the thrombophlebitis or failure, and when it's appropriate to infuse through a peripheral intravenous catheter. We also need to have a look at the terminology that is being used, because there's quite a lot of terminology used to describe different peripheral intravenous catheters, and this was one of the big changes in the new edition of the infusion therapy standards. We provided some definitions of key practices or terminology that really was not necessarily ambiguous, but had kind of broadened and had become a little bit loose in how some of the key terms were being used interchangeably. And so one of these things was defining peripheral intravenous catheters, because as you can see on this slide, there are multiple terms used to describe peripheral intravenous catheter. So vascular access clinicians, many of these things mean different things and some of them mean the same. So what was a long peripheral intravenous catheter or extended dwell peripheral intravenous catheter? So within the infusion therapy standards team, we really thought we need to pull it back and simplify those terms so that clinicians could understand each term and really understand the specifics of that particular term and the particular type of catheter it was referring to. And also by ensuring its standardisation, it helps with data collection and international benchmarking, and then making sure that we're reporting the same outcomes. So if you have a look at these terms that were ultimately used, this was how we defined the different types of peripheral intravenous catheters to try and standardise them. So a short peripheral intravenous catheter is essentially a over the needle with a hollow metal stylet, and that's positioned inside the catheter, and it's generally inserted into small superficial veins. And then you have a long peripheral intravenous catheter inserted into either a superficial or deep peripheral vein, and it offers an option when a short peripheral intravenous catheter is not long enough to adequately cannulate the available vein. So a long PIVC can be inserted either using traditional over-the-needle technique or with more advanced procedures such as Seldinger. And then also amongst the peripheral catheter suite is the midline catheter, and this is generally inserted into a peripheral vein of the upper arm via either the basilic, cephalic or brachial vein, and the terminal tip is located at the level of the axilla in children and adults. And for neonates, in addition to the arm veins, midline catheters may be inserted via scalp veins, and the distal tip is located in the jugular, above the clavicle, or in the lower extremity, with the distal tip located in the inguinal crease. So how do we choose which peripheral intravenous catheter to insert? So when we're looking at short peripheral intravenous catheters, when all infusion characteristics support peripheral intravenous therapy, a short peripheral intravenous catheter might be appropriate. However, for some time-critical, non-peripheral compatible life-saving therapies, they can begin in a PIVC. However, a CVAD should be inserted at the most safe time period or earliest time period. We should use restricted dextrose and protein concentration if medically necessary to infuse PN peripherally, and the recommendations for a protein concentration less than 5% and dextrose less than 10% are in the guidelines. And we generally suggest that we use the smallest PIVC for most infusion therapies. However, we can consider a larger gauge for rapid infusion. So ultimately, we should never upsize the gauge of the PIVC to achieve a longer PIVC. In that situation, if a longer PIVC is necessary, we should use an actual longer device. And a time when we would consider a longer device is in situations similar to what has just been described for a short PIVC, but also if the vessel is difficult to palpate or visualise with the naked eye. So it's likely it's going to be a deeper peripheral vein. And ultimately, if the depth of the short PRVC is going to be less than 2/3, we should consider using a longer PRVC. So now if we consider the evidence for selecting a short or standard length PRVC over a long PRVC, so Marsh and colleagues reported infiltration occurred 1.5 times more frequently when a 22 gauge PRVC was used in comparison to larger PRVCs such as a 20 gauge. However, at the time of this study, only short or standard length 22 gauge PRVCs were available in Australia where the study was undertaken. So it's prudent to wonder, was infiltration related to the 22 gauge catheter or was it the result of the shorter length design of a 22 gauge, which is typically 2.5 centimetres in comparison to the slightly longer 20 gauge and 18 gauge catheter that have been available for some time now in varying lengths of 3, 5 and approximately 7 centimetres. So whilst the longer length 22 gauge PRVC have been available in the international market for many years, that was not the case when this study was undertaken in Australia. So perhaps similar to the work that has been done investigating the catheter-vein ratio in PICCs, we should consider the significance of this in peripheral intravenous catheters. So two authors, Tanab and Pangandaru, have been investigating whether the catheter-to-vein ratio impacts PRVC outcomes. So Tanab investigated or looked at 79 PRVCs in 72 adult patients and reported that a catheter diameter or ratio of 3.3 or 33% was ideal, and that when this was lower, i.e., for example, there was more vein was occupied by the catheter, the risk of infiltration increased. Then in another study, another prospective observational study by Pangandaru, they attempted to quantify the ideal proportion of catheter length that needs to be within the vein to reduce the risk of failure. And in this prospective study of 86 patients, 33% of the intravenous catheters failed, and 100% of the PRVCs failed when there was less than 30% of the catheter in the vein. So when less than 1/3 of the catheter was actually in the vessel, all of those catheters failed. And then 32% failed when there was between 1/3 and 2/3 of the catheter in the vein. And then when there was, they found that when there was 2/3 of the catheter residing in that actual vein, there was no failure. And they further determined that for every 5% increase of catheter in the vein, the risk of failure decreased by almost 30%. So whilst these studies have similar findings, we need to remember that they are observational and quite small in nature and have all been done on adult participants. So we really do need to consider how this relates to our field of practice. So particularly for paediatrics, a longer PRVC might not always be appropriate. You might not actually have the real estate in the limbs to insert a longer catheter. And we also need to think that whilst more catheter is in the vein, the risk of stasis does increase slightly. So whether there's going to be an increased risk of thrombophlebitis or any type of phlebitis, that's something that probably hasn't been fully studied when you consider that both of these studies looked at less than 100 patients. So I think we haven't quite got all of the answers that we need on that yet, but it's certainly a starting point, and fantastic that people are starting to look at how else we can reduce the risk of failure. So now if we look at these Kaplan-Meier graphs on the screen, still looking at the long versus standard length PRVCs, this indicates, Kaplan-Meier graphs indicate the probability of an event at respective time intervals. So in this study by Ball, they compared the standard length PRVC to an ultra long PRVC. So on these figures, the black line indicates the ultra-long PRVC and the blue line indicates standard length or short PRVC. So as you can see, the ultra-long or the long PIVC had a significant increase in survival compared to the standard catheter group. And the median survival duration in the ultra-long or the long catheter group was 136 hours. And again, the terminology I'm using is what they referred to in their study. But if you look at the actual catheter lengths in the study, the ultra-long catheter was just longer than the standard catheter. And so it's, again, this is really important to get our terminology correct. So the median survival of the long catheter was 136 hours or 5 days. And this was compared to 92 hours or 4 days duration of the standard length PIVC. So this provided a difference of 44 hours. And these results are in the intention to treat analysis. But if you look at figure B, these were the protocol analysis, and the results were similar. So then if we look at the optimal catheter length in the vein, they also looked at this to maximise catheter survival. It was calculated at greater than or equal to 2.75 centimetres. And again, in the intention to treat analysis, catheters with greater than 2.75 centimetres in the vein had a median survival of 129 hours, so just over 5 days. And this was compared to 75 hours or 3 days in the standard length catheter group. So when less than 2.75 centimetres was within the vein, the dwell again was longer, as was the risk of failure. So the difference in dwell was about 54 hours, and this is quite significant when you consider how many PIVCs are going to be needed over the course of a patient's treatment therapy. And in addition, the multivariable Cox regression showed that the risk of failure in the long PIVC group was approximately 50% lower than in the standard group. So whether or not it's clinically, statistically significant, it's certainly clinically significant. So then if we look at similar studies in children, Quinn and colleagues undertook a randomised controlled trial comparing the long PIVC to standard length PIVCs against a small number. This was a randomised controlled trial though. 72 children aged between 1 and 17 years were randomised to receive either a standard length PIVC or a long PIVC. And they were only randomised, or they had to require intravenous therapy for 48 hours or longer to be eligible to participate. So you can see on the table to the left, the standard PIVCs were 3.5 times more likely to fail than the long PIVCs. And then if you have a look at the graph on the right, it shows the median dwell of long PIVCs was 5 days compared to 3.5 in the standard length group. And in the study, infiltration was the most common cause of PIVC failure. So then the final catheter definition within the suite of peripheral catheters is a midline catheter. So when we consider the utility of midline catheters and we debate the rationale for their re-emergence into the vascular access arena, we still don't have a lot of high quality clinical data guiding our practice. So we certainly need more high quality studies using standard outcome definitions to increase the knowledge base regarding the use and outcomes of midline catheters. So to date, we know that they should only be used when intravenous solutions have properties appropriate for peripheral intravenous infusion. Multiple prospective studies support their efficiency for infusion durations of up to 14 days. However, we need more studies to confirm the safety and efficacy of their using them for beyond 14 days. And in one prospective observational study by DeVries and colleagues, they reported no catheter-associated bloodstream infections when a midline catheter that inhibits bacterial attachment and biofilm formation was used. However, in another retrospective study by Hogel and colleagues, when they compared the incidence of bloodstream infection when midline catheters without enhanced catheter material were compared to various types of central lines, including PICCs, non-tunnelled and tunnelled CVCs, this study did not find a significant reduction in CABC. So importantly, it should be remembered that midline catheters should not be used as a CLABSI reduction strategy. They do have their own purpose, and they shouldn't be used to negate a central line bloodstream infection, because obviously if that infection was going to occur, you're just shifting the focus of the infection from one device to another. So in a study by Dr. Chopra and his team in Michigan, they published what is probably the largest midline cohort study to date. And this was the outcomes of multiple healthcare institutions. So they reported 1,161 midline catheters. And in this cohort, minor complications occurred in 10% of their catheters. This included dislodgement, leaking and infiltration, and they had a low rate of major complications such as occlusion, deep vein thrombosis and infection. So they concluded that midline use and outcomes varied widely across the various hospital and healthcare institutions included in their study, and that we really needed to better define appropriate indications for use, optimal insertion technique and best care and maintenance practices to ensure longevity and patient safety. So this study also recommended that studies evaluating the performance of midline catheters greater than 14 days when single therapy peripherally compatible medications are infused are needed, because again the dwell within this cohort of catheters was up to 14 days or fewer. So to determine how acceptable and efficient midline catheters are past that 14 days, we really need to get some more literature and data to support that. So with the available evidence, it is fair to say that midlines should not be used to deliver vesicant drugs. They're less likely to perform well when multiple infusions are required and when infusion therapies of extreme pH and osmolarity are needed. So similarly, good evidence, although this is a largely retrospective and cohort in nature, exists to restrict insertion of midlines when the patient has a history of thrombosis, hypercoagulability, decreased venous flow to the extremities, or end-stage renal failure. So another change to the infusion therapy standards of practice in this new edition is the move away from pH and osmolarity as the sole predictor of peripheral compatibility. And I think there is a little bit of confusion about not including the pH and osmolarity range in the infusion therapy standards, where it's assumed that that isn't important. It's not that it's not important, it's just that it's not the only factor that needs to be considered when we're trying to determine if an infusion is peripherally compatible or not. So emerging now in the literature is the risk of endothelial cell toxicity. And a common example of this is the infusion of vancomycin. So it is commonly associated with phlebitis. However, it is probably one of the most frequently infused medications in routine hospital practice, and frequently used as empirical treatment before sensitivities are returned. So whilst ideally this should be infused centrally, are you really going to place a central line whilst you wait sensitivities, which might only be 24 to 48 hours, at which point a peripherally compatible antibiotic might be deemed appropriate to treat a particular infection? So the million-dollar question is, when is it appropriate to infuse via peripheral vein, and for how long before complications are likely? So this study that you can see on the screen now by Druitt was published in 2015, and it demonstrates that some concentrations of vancomycin might be safe to administer peripherally. But the aim of this in vitro study was to assess vancomycin endothelial cell toxicity. So they challenged endothelial cells at clinical drug doses, comparable drug concentrations, and documented the point at which cell damage occurred. So if you have a look at the graph at the bottom left, you can see that as the vancomycin concentration increases, cell viability decreases. And starting at a concentration of 1 milligram per mil, most cells are viable, but as you move down to 10 milligrams per mil, only 20% of the cells are viable. So this means at this concentration is very high cellular toxicity. The results of this study show an increase in endothelial cell death from vancomycin at a concentration of 2.5 milligrams per mil onwards, and concentrations of 5 milligrams and 7.5 milligrams start indicating reasonable cell death. So when vancomycin needs to be administered at these concentrations, it really should be delivered via a central line where the drug can be more naturally hemodiluted and less likely expose the endothelial cells to toxicity. So if you're administering vancomycin peripherally for that short period of time, you really need to consider how you dilute this safely so it can be administered into the peripheral vasculature safely. But now if we look at the graph to the right, this considers the influence of vancomycin pH on endothelial cell toxicity. So you can see when vancomycin is at a similar pH to normal saline, whilst normal saline maintains full cell viability, vancomycin solutions of similar pH result in much greater cell death. So again, this suggests that vancomycin toxicity is not induced by acidic pH, but rather some other property. So this just again highlights why pH is not the only consideration that we should be thinking about. So then finally, if we have a look at the graph in the middle, they compared the intermittent administration to continuous administration. So you can see when vancomycin is administered continuously compared with intermittent infusion of the same daily dose, the continuous infusion induced greater cell death than the intermittent infusion. So this might have something to do with the greater time in contact with the cell wall. So the point of this is that whilst this in vitro data is not derived from clinical trials, it is still useful to guide our clinical decision-making. And this demonstrates clearly the complex decision-making around peripheral suitability of many of the common parenteral drugs that we administer on a regular basis. And about 18 months or about a year, 18 months ago, Dr. Ryder and her team undertook a randomized controlled trial in sheep subjects. So the aim of this ovine model was to investigate the vascular endothelial cell toxicity when various parenteral medications of varying peripheral compatibility were administered via midline catheters. So in this blinded randomized controlled trial, 24 sheep were randomized into 6 study arms. 20 sheep catheters were available for analysis at the end of the study. So the dwell dwell of the catheter was 7.5 days, and that ranged from 3 to 14 days. The results of this study demonstrated that prolonged exposure to infusions that are likely to cause endothelial damage, such as acyclovir and parenteral nutrition with an osmolarity of greater than 600, and vancomycin showed signs of complication, and they failed earlier. Unfortunately, the control catheters were removed at the time of the test catheter failure, regardless of whether they were showing signs of complication. So the absolute dwell potential of these devices infusing a more normatomic solution was not known. But another interesting finding in the study was that the control catheters inserted into the contralateral leg of the sheep that were randomized to known high-risk medications such as vancomycin 10 milligrams per mil or the hyperosmolar PN solution failed earlier than the control catheters of the less toxic infusions. So this is interesting because it adds to the growing body of evidence of systemic thrombophlebitis that suggests, regardless of the site of infusion, the systemic effect of the more toxic infusion might influence the control catheter and ultimately put our entire vasculature at higher risk. So whilst this wasn't a human trial, I think we can safely say the sheep took one for the team, and we don't need to replicate this in human trials. And they do point out in the manuscript that the sheep or ovine models are very similar in their vasculature to humans. So I think we can use this information to help inform our practice and limit the use and duration of use of peripheral devices, including midline catheters for infusion of more irritating medications. We should also consider what human trials are important for the future, and these should focus on peripherally compatible infusions to determine the appropriateness of the devices and length of dwell. Sorry, I forgot to go forward a slide there. So now if we look at the types of medications that are frequently administered, and after going through the complexity of making these assessments, there's been some debate about whether there's any value in establishing lists that indicate the risk of infusate. So there are multiple arguments for both sides of this discussion. So due to the complexity of the decision-making process, lists are difficult and often inconclusive. However, they do provide a very useful starting point and something to guide our practice or initiate a conversation for risk assessment. So it's important to remember, if you're going to use a list, you need to use it in conjunction with other variables, such as the patient factors that we've discussed, how you dilute it within your institution, particularly given the information that we just looked at the varying cell death at various concentrations. Also consider the insertion site. And so essentially these are two published lists, and this might be useful for you to start off a list within your local hospital, but it would be quite prudent to work with your pharmacist to actually develop a list that's going to be most relevant to your patient population and the common concentration of medications that you frequently infuse in your hospital. So a more comprehensive publication of these different types of medication lists by Manrique Rodriguez recently reviewed the literature, and they developed the endothelial toxicity score for some of the most common adult medications in frequently administered drug concentrations. So whilst the lists that we can see here provide risk factor in terms of low risk, medium risk and high risk, this publication actually went on to rank the various concentrations and the association with endothelial toxicity that those concentrations have. So I know you're all thinking, just give me a list, just tell me what I can infuse peripherally and what I can't. And unfortunately, it's really not that easy. Even in my daily practice, I often have the same thought. I just wish there was a standard list and it was black and white, what could be infused peripherally and what couldn't be. So these are the complex decision-making or shades of grey in this infusion decision-making. So I think one of the bigger questions, rather than what can and can't be infused of the non-chemotherapy type cytotoxic drugs, is how long is too long for peripheral infusion? What's the threshold for infusing these irritating medications through a peripheral device? So again, unfortunately, these answers are not black and white either. What is the ultimate duration of therapy is something that needs to be considered. What is your particular patient's vasculature? Because the length of appropriateness of infusing some of these cytotoxic medications might not necessarily be the same. It would really depend on your individual patient's vasculature and their disease state. What is their peripheral vascular access? How many previous peripheral intravenous catheters have they had in this current admission? Is it a prophylactic dose of this cytotoxic medication? Is the patient stabilising or deteriorating? When do I consider inserting a central venous access device? So particularly for paediatric patients, this is a frequent conundrum because not only are there risks associated with insertion of a CVAD, but frequently these children will require a general anaesthetic or sedation. So there are these risk factors to consider also. So in this systematic review by Libani, this is a good example of safe limits of vasopressors through peripheral intravenous catheters and central venous catheters. So after searching the literature, they found 85 studies to include, and these reported the results of 270 patients with 325 separate events of local tissue injury or vasopressor extravasation that arose from the administration of pressors. So the events were categorised as either extravasation, so there was evidence of drug escaping into the surrounding tissue with or without injury, or local tissue injury. So there was evidence of tissue injury with close association to the administration of pressors that were not mutually exclusive. So you could have extravasation with tissue injury. So 64% of the events cause local tissue injury, and 98% of these injuries were associated with peripheral intravenous catheters. And of the tissue injuries, some of them were not significant and did not necessarily include skin necrosis. Some of them did include skin necrosis, tissue necrosis, or gangrene. When considering the drugs that provided most risk, norepinephrine was a culprit in 80% of the reported cases. And when considering the location of risk, 2/3 of the injuries occurred when the peripheral intravenous catheters were inserted distal to the antecubital fossa or in the knee, and the remaining 1/3 occurred at the antecubital fossa or more proximal. So when considering the duration of dwell to event, the median duration was 24 hours for a peripheral intravenous catheter prior to injury. So most injuries occurred after 6 hours of infusion. So the most common catheter gauge that resulted in extravasation was 22 gauge. So the authors concluded that administration of vasopressors via peripheral lines for short term, i.e. 2 hours or fewer, but no longer than 6 hours might be appropriate. So this is not a very long period of time, but it really does give you the opportunity to use a temporising peripheral intravenous catheter as an emergency measure, but they do stipulate that this should be replaced as soon as possible with a central venous catheter. And so knowing that there's some quite complex decisions to be made, and unfortunately not all healthcare facilities have experts at the ready to help with these decisions. So until experts are widely available at every location, we need to ensure that everyone has access to the same level of expert knowledge and that this is provided in simple language. So to ensure fair and equitable healthcare for everyone, we need to make sure that this is in a format that non-experts can easily access and make those same complex decisions. Because although clinicians aren't experts in every aspect of healthcare, they really do still want to do the best for their patients. So to help with this, the recommendations for the intended duration of therapy in the infusion therapy standards of practice is largely based on the two MAGIC documents. So you can see the adult MAGIC document on the screen there. This has various device outcomes and bases your decision making around this, and that the patient caregiver preference as well as any published outcome data will help inform any future iterations of these guidelines. So it really gives you a length of treatment that is appropriate for different intravenous or peripheral intravenous devices as well as your more central devices. And so then if we look at the paediatric guide, you'll note that it's considerably more complex than the adult guide and is broken down into neonate, infant and adolescent. However, we didn't include premature neonates because they do have more, they're a more special group with their own special needs. So you'll note that there's considerably more ambiguity regarding the appropriateness of device. So ambiguity is denoted by the yellow shading. And this is not that it's inappropriate, it's just that there's a lack of evidence to support that type of device for a particular type of therapy. So again, not for the first time, I'll say it again, we need more data. No matter how big or small the study, it all contributes to the pool of evidence. So not only is Mini-MAGIC divided by patient age, but in recognition of the various complexities of some specialty groups, there are different guidelines for various subspecialties, including cardiac, hematology and oncology, as well as children who will have long-term vascular access dependencies, such as children with cystic fibrosis and PN dependency. And also children that we know will need vascular access for greater than 1 year and don't meet other subgroup criteria because they need specialist vascular access. And this includes the DIVA patient population as well. So once we've decided that a PRVC is the most appropriate device, whether it's a short or long PRVC, we need to optimise the chance of survival of the catheter by carefully choosing the insertion site. So in this study by Fields in 2012 in adult patients, they reported ultrasound-guided PRVC insertion in the antecubital fossa or forearm was associated with improved survival compared to more proximal placements in the region of the brachial or basilic veins above the elbow. And in paediatric patients, this randomised controlled trial by Takeshita showed that catheterisation success rates were significantly greater at the cephalic vein in the forearm than in the dorsum of the hand or the greater saphenous. So this is kind of a summary table that I won't go through in too much detail because it's kind of everything that we've just been through. And I think the time is kind of scooting along. So I just want to quickly touch on the difficult intravenous access patients as well, because that is starting to make up quite a large cohort of the patients that we see. So DIVA is defined as a clinical situation where multiple attempts or special interventions are required to obtain and maintain peripheral access. So while the average child might require 2 needle sticks for successful PRVC insertion, children that are considered to be difficult intravenous access are reported to experience upwards of 9 cannulation attempts. So this really does increase the complexity and emotional experience of inserting peripheral intravenous catheters in not only paediatrics but in adults as well. And whilst there are various tools that are validated for various clinical groups, these are mostly in adults or in the emergency department. And what we lack is what do you do with a patient once you identify them as a difficult intravenous access patient? So the most common type of tool that has been used frequently in the literature is Yen's 4-point tool. So this was validated in the emergency department for paediatrics. They allocated a score of 0 to 2 for each variable, and they concluded that a score of greater than 4 had a greater than 50% chance of first-time insertion failure. So the problem with this tool is that it doesn't, once it identifies a patient as a DIVA, it doesn't actually tell you what to do with that patient or how to improve their chances of first-time insertion success. And similarly, in the adult population, Van Loon recently published the adult DIVA scale, and in this study, they aim to provide clinical predictors for difficult intravenous access. So they found that when palpability, visibility, or a history of DIVA or unplanned indication for surgery, or if the diameter of the vein was less than or equal to 2 millimetres, they had an increased risk of the patient being known as a difficult intravenous access. And you can see this is the scoring system that they used. So again, it doesn't actually tell you what to do once you determine a patient to be difficult intravenous access. The closest that we have to this in the adult population was a study by Hallam. They attempted to address the lack of direction, and this vessel health and preservation framework for peripheral vein assessment put a lot of importance on visualisation and palpability of vessels. And I think that's probably the take home, regardless of all the other factors that might go towards a patient being considered difficult. we always get back to that same, are there palpable or visible vessels? So in this tool, it was validated for adults, and they have a suggestion of the skill level of the clinician who should attempt peripheral intravenous access. But if you look at grade 5, it essentially says in someone with non-palpable or visible veins, access shouldn't be attempted. So what actually happens to those patients? How do they get their peripheral intravenous access? So in our paediatric cohort, we attempted to tackle this and develop a DIVA tool that is relevant to all clinical areas. So after many iterations and with the assistance of clinicians from various clinical groups and consumer input, we came up with this mnemonic where you look at the acuity, the age, the appearance and anxiety, and rate patients as low, medium or high risk DIVAs. And at the same time, the clinician has a level of self-assessment so that they rate themselves as a green, yellow or red inserter. And ideally, the red inserter, so the most advanced or experienced inserter, will always have the first attempt on that high-risk patient. But obviously, with the various healthcare services, that may not always be possible in all healthcare facilities. So just finally, there's a strong evidence to use ultrasound for PRVC insertion in adults. This systematic review published in 2018 included 5 randomised controlled trials and 3 cohort studies in 660 patients. And you can see with the diamond at the top, which is comparing ultrasound to standard care in all comers, it is still crossing the line of equivalence. So it's not that ultrasound is the best approach for every patient, but if we look at the forest plot below, you can see that the diamond is clearly on the side of the ultrasound, and this is for patients who are determined to be difficult intravenous access. So this suggests that it might not be necessary for every patient, but there's certainly strong evidence for its use in the adult patient or DIVA patient cohort, and we really do need similar evidence in paediatrics. So again, there's, whilst there's strong evidence for using ultrasound, it does take more than just a needle and an ultrasound to insert peripheral intravenous access on the first time using ultrasound. So you're always going to go through this learning curve, or it's hard to get there to start off with, but you think you've got it, but then you go down this slump again, and it's just constant up and downhill battle until finally you really are at a point where you kind of feel like you've nailed it. But this might take quite a few insertion attempts, and it's not going to happen immediately, and it does require teaching time and good technology. So we need to consider the type of ultrasounds that we're using. So I guess the take-home message is vascular access is a marathon, not a sprint. Take the time to assess your patient, know the anticipated treatment plan, know this might change and your vascular access treatment plan might have to change with it. Consult the resources available to you, consider the DIVA risk, and do you have the appropriate staff and the appropriate technology to maximise your chance of first-time insertion success? And ultimately, and most importantly, are you the most appropriate clinician at this time to insert the PRVC? So I'd just like to thank everyone for listening, and I hope we have some time for questions, and I'll hand it back to Jayant now.
Hey, thanks, Tisha, for sharing your knowledge and experience with us. It was an incredible amount of information that you shared. And I also like to thank our wonderful audience for joining us today. I'll now open the discussion to some of these great questions that have come in, and these questions are really very close to the practices in the hospitals. The first question here is, what exactly is meant by the level of axilla in reference to midline terminal tip location?
Yeah, I think this is quite a frequent question. And I think a lot of clinicians think that it is just one defined location. So essentially, the level of the axilla should really be based on patient assessment. So ultimately, we want it to be below that axillary fold, and we certainly don't want it crossing the axillary fold into the chest area. So most midline catheters are inserted with ultrasound today, so you're really able to assess the entire path of that vessel. So ultimately, the terminal tip of the midline catheter should be where the vein is at its largest at the area of the axilla. So if you look at the axillary fold and look just below that, any point there where the vein is at its largest would be an appropriate place for the level of the axilla.
Thank you, Trisha. Another great question here. And before I read that out, I'll probably announce that we'll take a few more minutes before we end the webinar for today, so that at least we are able to address a couple of these common, frequent questions that come across in our day-to-day practice. The next question, Trisha, is you talked about the venous purchase and prefer long peripheral catheters for that purpose. So do you anticipate more complications with longer PIVC, and would you recommend a smaller gauge to overcome this situation?
So I think if I've understood the question correctly, do I anticipate more complications with a longer PIVC, and should we use a smaller gauge to mitigate some of these? I don't know if we know the answer to that yet, whether there is likely to be more complications with the longer PIVCs. Certainly in some of the published literature, it does appear that there are fewer complications in terms of failure, such as infiltration. But again, not always all outcomes reported. So infiltration might be fewer in the longer PIVC, but phlebitis isn't always reported in the literature. And I don't think you necessarily need to put a smaller gauge catheter in, but think about the type of therapy that's necessary. And again, the same mantra, always insert the smallest gauge catheter that is appropriate for that therapy. And ultimately, don't upsize your catheter just to get a longer PIVC.
Thank you. That's amazing. And I'll take last two questions for today. The second last question is, at our hospital, we tend to use a BD Insight AutoGuard 24 gauge with 1.4 centimeter length peripheral IV catheter for a vast majority of our pediatric patients. So this is closer to your practice. And the question is, what would you advise is most appropriate length for our young pediatric patients?
So again, I think if we try and pull together the various aspects of the presentation, if we're trying to get at least 2/3 of the catheter in the vein, you really need to have the vein quite superficial if you're just going to have a 1.4 centimetre catheter. So it really can't be much deeper than 0.3 centimetres under the skin surface. So that's quite a superficial vein. There are longer longer lengths in the 24 gauge available. To my knowledge, there's a 3 centimetre 24 gauge PIVC. So that might be appropriate if your vein is deeper than sort of half a centimetre at the maximum. But again, it's looking at all those different assessment tools that we've been talking about, using ultrasound to assess the depth and thinking about how much catheter is actually going to be in the vein. And also the length of treatment. If it's for a one-off infusion, it might not necessarily require a long PIVC. And also think about how you're going to dress and secure the catheter as well.
Great. Thank you, Trisha. Another amazing question is, is the medication list provided by INS for vesicant irritant drugs? Or if the medication is not listed, can we consider a high pH and osmolarity to be a vesicant or irritant drug?
Yeah, I think extreme pH and osmolarity is listed in the infusion therapy standards as your guide. So rather than having actual pH numbers, so I think the previous iterations of the infusion therapy standards suggested between 5 and 9 pH might be appropriate. But now we talk about extremes of pH. So again, there are patient factors that are going to influence what the patients can tolerate. So a patient with diabetes mellitus, for example, they might have a more narrow acceptability of that pH range, whereas a very well patient who's coming in for a particular infusion, probably not coming in if they're very well, but if they don't have chronic illness or comorbidities, they are probably more likely to tolerate those broader extremes of pH, so getting closer to the 11 mark. But again, that's something that we need to take into consideration with the patient, the device and the infusion.
Great, thank you, Tricia. And I would like to apologize to our great audience today. I wish I could present all these questions to Tricia and get the answers for all of you, but I think time is a limitation today. And with that, we'll end our question and answers here. We weren't able to answer every question, but we will do our best to follow up and answer them all. So as next steps, I would like to announce this presentation will be available for viewing on demand. You will receive an email with the instructions for that. Please remember, do not close the presentation or browser right now and answer the questions that will appear on your screen to get a certificate of completion. If you have any questions, feel free to reach us at the email address vam@pd.com, and we will try and respond to your questions. Please stay on the line to complete a short survey and receive the certificate of completion. And that concludes our presentation for today. Thank you so much for joining us. Thank you. Bye-bye.
Thanks, everyone.